Hello and welcome. We have Dr. Subba Reddy with us today. Hi, sir. How are you?
Hi, I'm Dr. Subba Reddy. I'm Director Critical Care at Apollo Hospitals, Hyderabad. I'm good. How are you?
I'm fine, sir. Thank you. Thank you for joining with us today. Few questions I would like to know what your ideas and thoughts are about. As a leader in critical care, what does effective leadership look like in the ICU?
Like ICU is a very complex area. We see very seriously ill patients in ICU. So ICU leader should be empathetic and he is the one who drives a highly skilled, a multidisciplinary team. And this team should deliver best outcomes. So the leadership truly means for ICU is it should be empathetic, compassionate, and then with a very sound clinical knowledge driving all the clinical teams working for intensive care unit.
So, what is that one decision, leadership decision, that significantly changed how your unit functions today?
If you look at critical care 10 years ago, it was general multidisciplinary critical care units across the country. So when I took over critical care at Apollo Hospitals, I understood the importance of subspecialty training in critical care. So if you look at the medicine, every branch is subspecializing. And in critical care also, we are having subspecialties ICUs. If you look at the neuro intensive care at Apollo Hospitals, we do complex neuro interventions and these patients get right care in a neurocritical care unit. Again, one of the flagship departments for us is a cardiology, cardiothoracic surgery, and we have highly advanced cardiac critical care. And these ICUs are manned by people who has a general critical care fellowship, and then they went for subspecialty critical care training like neurocritical care, cardiac critical care, surgical critical care, transplant critical care. And these subspecialty ICUs focus mainly on high-end cases who like coming to those ICUs. They get right care in those ICUs.
So, what, according to you, is the way we are evolving in the critical care department? Is it in lines with more awareness or technology?
Yeah, technology is very important for a branch in medicine. Intensive care units are technologically intense departments. We see a lot of gadgets in the ICUs and new gadgets we are adding. But this technology will help us giving more precision to the patients to drive best clinical outcomes. At the same time, technology cannot replace good clinical judgment of an intensive care physician.
So, what will define the next phase of critical care in India, and how do we align with global standards while addressing our local challenges?
So if you look at next phase of growth or next phase in critical care, so you should standardize intensive care across all the areas. If you look at intensive care at big cities and tertiary or quaternary care hospitals, it is like more standardized and then we deliver best outcomes in those units. At the same time, when we have level 1, level 2 ICUs in type 2, type 3 cities, and you have to focus on those areas and to give to standardize those ICUs, and then you should develop a critical care network and then you should get connected to these ICUs. And the remote monitoring is one thing which is playing a big role in maintaining this standard of care across all the intensive care units in the country.
So, do you think this is becoming more centralized in advanced centers and decentralized in peripheral centers?
It was centralized in big units before. Now it is decentralizing. Even type 2, type 3 cities have very good ICUs and then they're driving good clinical outcomes. That is basically because of the training programs we can able to scale up, and then we are doing capacity building of these intensive care physicians, and these people they're going to smaller towns and then they are running good intensive care units there. So it is more like decentralized now in India. We see good units across the country.
Okay. So, what is one quality improvement measure in ICU practice that you believe is still under implemented?
Most of the units have standard quality metrics for intensive care unit, whether you take infection control metrics or whether you take medication errors, hand hygiene complaints. So different quality metrics are there for intensive care units. But one thing which still lacking in many units is implementing electronic health records in the intensive care units. When you implement electronic health records, then we will get large data, and then there is less scope to do errors, and everything is integrated. Now we have a lot of monitors who go to the patient. It is practically impossible to document everything in the case sheets, and then when you have EHR, everything is like recorded, and there is no scope for manipulation and no scope for error when you implement EHR. I think this is one area where we are focusing, and we are moving towards electronic health records in the intensive care unit.
So you are a teacher and you have trained many critical care physicians under you. Over the last decade, what is that one mindset shift you have seen in the younger physicians?
So one great thing which I'm observing in these younger critical care physicians is like they're very versatile. Before, when I was in critical care training, we were thinking we have to focus only in critical care. Now we have a lot of opportunities. As a critical care physician, you can work in intensive care unit, or you can work in tele-ICUs. Many people are going towards tele-ICUs, and some people are doing these management degrees, and then they're going towards medical administration, and some people they're going towards research and innovation. There is a lot of research is going on in ICUs, and I'm happy to see some of our students going towards innovation side, inventing whatever like patient cots and then ECMO machines, because all these gadgets are very expensive, and when you develop indigenously, and that will be more cost effective. So now there are a lot of opportunities, and then they're looking at these opportunities, and then they're going towards subspecialty training. As I told, they're not trying to stop with that critical care fellowship. They go into subspecialty training like ECMO training, ECMO fellowship, and then they're becoming ECMO physicians, and then they're leading these lung transplant ICUs, and then they're leading ECMO units now.
So since you brought up ECMO, where do you see ECMO fitting into the larger critical care framework in India over the next 5 years?
So there is a lot of scope for ECMO. Now when you can't ventilate, we have option. And even the awareness in Type 2 and Type 3 cities is great for ECMO. And we get a lot of calls for our ECMO outreach team. Next 5 years, I think we will have more and more missions, more hospitals will be doing ECMOs, not only in big cities, even in small towns, they're trying to do ECMOs. And at least they're going to initiate ECMO and transfer this patient to a quaternary care center or tertiary care hospital. And the outcomes are also, I think, next 5 years, if you look at ECMO outcomes, they're going to become much better. And we are going to produce many ECMO physicians in next 5 years. And I think in next 5 years, it will become more simple, and it will more standardized, and then we'll have good protocols across all the units, and even the outcomes will be much better.
The government, what role or policy do you think the government can help in the upcoming advanced therapies, or providing support to the public for ECMO?
Government can do a lot of things which they're already doing even for ECMO program. One thing is they should have public-private partnership for these high-end procedures, where in government hospitals, when they don't have trained physicians, and when they don't have required infrastructure, they can have a public-private partnership, and then they can do ECMO programs and high-end medical care through PPP model, and driving these insurance programs, insurance companies, and allowing them to accept ECMO as a standard of care for people who require, and then giving ethical practice for the ECMO. Like if you look at, there should be some regulatory control on ECMO. So everyone cannot do, at least they should do certain number of ECMOs to call it as a ECMO center, and then they should give recognition for those centers so that the outcomes will be better. Otherwise, if they're doing around 4 cases, 5 ECMOs in a year, so that will not be enough to produce the best outcomes. So they can get this regulatory change, and then again bringing awareness amongst healthcare people and in public about ECMO program, and again in government tertiary care hospitals, and setting up very good ECMO units will also help the public who cannot reach out to private hospitals.
Okay, so how do you move from protocol based care to consistently delivering high quality outcomes across your team?
last decade, we have seen the protocol-based critical care practice showed like improvement, but definitely we can do now. If you look at cancer therapy, it is more precision based therapies. Even in critical care, we have seen now the evidence is showing a lot of phenotype based diseases. If you look at sepsis, if you look at ARDS, these patients may not respond if you practice uniform protocols for all the patients, because we see different phenotypes. Some people will respond to high peak, some people will not respond to high peak. In sepsis also, some people will have hyperinflammatory phenotype and some people will have hypoinflammatory phenotype. So unless you go for that precision medicine, your outcomes will not be very good. And then the pharmacogenetics, and to select the right drug, because we see polypharmacy in ICU. To select the right drug to the right patient, again, pharmacogenomics is very helpful. So one size will not fit all. So we are moving towards precision medicine even in critical care.
So coming to AI, with a lot of fields moving ahead in AI, what is the role of AI in critical care?
Everyone talks about artificial intelligence in medicine, but in intensive care units with advanced ventilators and with these AI algorithms, we have better modes. And before, the intensive care physician used to spend a lot of time with the ventilator to wean the patient, to adjust the ventilatory settings. But now this AI integration, so now we have better ventilators. We spend less time, and these ventilators are giving better care than the older version. And we get a lot of data from patients in intensive care unit. Using this data, we are developing our own algorithms to improve the ICU care. And ICU is a dynamic area where you see a lot of changes in different organ systems, like kidney functions will be changing every day, liver enzymes will be changing every day. And drug dosing based on these changing parameters will be very difficult if you don't have AI models in your ICU. So AI is going to play a big role in intensive care unit. Again, it will not replace any intensive care physician. And then ultimately, the clinical judgment is more important. AI can help you in as a clinical decision support tool, but it will not replace any trained critical care nurse or physician or even a technician in intensive care unit.
So with the ongoing social media presence, what if you're given an opportunity, what is that one message you would want to deliver to the public?
So we should try to avoid intensive care admission. For that, we need to do everything. See, we focus on non-communicable diseases. We focus on lifestyle change, weight reduction, better diabetes control, better hypertension control. But at the same time, we are trying to forget our communicable diseases, our infections in the community. And when the AIDS catches you, there is cell senescence and immunosenescence. When there is immunosenescence, when the immunity is dropping, when you are becoming old, and adult vaccination is very important. Like you take pneumococcal vaccine, flu vaccine, typhoid vaccine. There are a lot of adult vaccines, but we don't give much importance to them. So we still see patients coming to the medical intensive care unit with influenza flare-up and then requiring ventilator, requiring ECMO. And then we even see middle-aged people because of the less immunity. So my advice to people is no need to be afraid of intensive care units. Our outcomes are very good, and we have very good ICUs, and we have family-centered ICUs. We allow families into the intensive care unit. They spend a lot of time, and then because of that, they will not have any post-ICU or traumatic stress disorders and all. You try to avoid this ICU admission if you control your health in a better way. This is one advice
you would like to give. Yes. So finally, what does progress in critical care truly mean to you?
The progress of critical care for me means it should be accessible to everyone in the country. And now critical care is becoming too expensive. One ICU admission for a patient will take away their entire savings. And we should become cost sensitive, and we can achieve this by decreasing average length of stay and then preventing infections. And when they come for any surgery or any complex procedure, they come to the intensive care, and then we should try to send them back without doing any harm to them, without giving any infections. And then again, capacity building and then having this critical care network in the country and hand-holding smaller units, improving their protocols, standardizing those intensive care units, and whenever possible, connecting to the tele-ICU, monitoring these remote ICUs, helping them, and even like Government of India is doing these 10-bed ICUs, district hospitals, and this 10-bed ICU is focusing mainly on standardization, training, capacity building. So when we achieve that, when you can provide uniform care across the country, I think that is true progress in the intensive care.
Very well answered. Thank you so much.
Thank you.
And we look forward to seeing you at ELSACON.
Thank you so much.
Thank you, sir.
Dr. Rana.